going to be much better. Maybe the next one on next Friday is going to be much better.
Yes, sure.
Yeah.
Keep up.
Yeah, thank you. So Karim, are you ready with your presentation now?
Sure, Mohammed. Hello, everyone. I hope you all are safe and your family are fine. We have actually a great expectation about this project, and without your contribution, I think we will have a lot of difficulties. So this is our first project, which is discussing the pulmonary hypertension. Actually, when we look to the patient with pulmonary hypertension, we think that it is a dilemma in the diagnosing and managing this type of patient. However, at first, let's simplify the approach for managing this patient. Let's manage him as a everyday patient with acute coronary syndrome. So the patient with acute coronary syndrome, you are going to take a history from him and doing a probability of a coronary artery disease. You'll have a differential diagnosis for the coronary artery disease, and you might need imaging. Then you will risk stratify your patient, and you will select the appropriate management. And this is the case with the pulmonary hypertension. I will start with the conclusion. You need to know the pulmonary hypertension probability. You need to search for the cardiac and lung causes, and we will say why we need to search for these causes. You need to exclude the chronic thromboembolic pulmonary hypertension, and if you are dealing with a patient with pulmonary arterial hypertension, you should know the cause, and you should do a right heart cath for him. Then you should go to risk stratification, selecting the appropriate.
So, Dr. Karim, I'm Haytham Soliman, and I'm honored to be your co-host. So you've enriched us with a lot of probability of pulmonary hypertension patient and a lot of interactive diagnoses and causes. Can you hear me?
Yes, it's perfect. It's perfect. No
Hello?
problem. Proceed, guys.
Okay. So I hope that you can solve this puzzle in the next slides. And I invite all our participants and all our guests to participate by raising hands when we ask the question. Go ahead, Karim.
So we will go through this presentation with a multiple MCQ questions, and this is the first one. Do you think the patient with pulmonary hypertension has a classic symptoms that are related to the degree of pulmonary artery pressure elevation? Is this statement is true or false? Okay.
Tobga here said false. I think we are the majority agree that this is a false statement.
Okay, the answer will come in the following slides. Actually, when we are dealing with pulmonary hypertension, there is a many simple answers, but it might be wrong, such as prescribing a calcium channel blocker for any patient with pulmonary hypertension. This is a wrong practice, and we have some right. I don't need to say it's complex answers. It's a right answers, and you need to work smart, not hard, for detection of the cause of the pulmonary hypertension, and you need to stick to algorithm. Why? Because you have many causes of pulmonary hypertension. The dilemma in pulmonary hypertension is in the diagnosing. The diagnosis needs that you go through many causes. We are talking about pulmonary arterial hypertension as a group 1, pulmonary hypertension due to left heart disease as a group 2, pulmonary hypertension due to lung disease as a group 3, and chronic thromboembolic pulmonary hypertension as a group 4, and the multifactorial pulmonary hypertension as a group 5. So how we, as Haitham said before, how can we solve this puzzle? Let's go through this case. She is a 55-year-old woman. She is a smoker and hypertensive, and she complains of shortness of breath and fatigue of 18 months duration. And she also has a history of fractured femur 1 year ago. On examination, she is obese. She had accentuated pulmonary component of second heart sound and systolic murmur over the left lower sternal border and mild ankle edema. And by doing echocardiography, it reveals that this patient have a right ventricular dilatation and elevated pulmonary arterial systolic pressure. So the pulmonary hypertension is here, and you need to detect which type of pulmonary hypertension. Is it type 2? Remember, this patient is smoker, hypertensive, and obese. Is it type 3? This patient also is smoker and obese that can precipitate COPD. Is it the type 4? This patient have a history of fracture of lower limb with possibility of the venous thromboembolism, or is it type 1, which can be a diagnosis of exclusion? And actually, as you mentioned, the answer for the first question is this is a long statement. This is because the most of pulmonary hypertension patient have non-classic symptoms. The non-classic symptoms can vary between shortness of breath, fatigue, angina, or syncope, and these symptoms don't depend on the degree of pulmonary artery pressure elevation. You might have a patient with a pulmonary artery pressure over 50 and you have a severe symptoms, and you have a patient with 80 millimeter mercury and he has a mild symptom. At a later stage, this patient may present with a right ventricular failure with ascites and lower limb edema.
So Karim, do you have any explanation of this discrepancy between the symptoms of the patient and the degree of pulmonary artery pressure elevation?
Simply because most of those patients seek the medical advice very late. It was estimated that the duration between the onset of the disease and the symptom onset, it can be up to 2 years, and the patients can have 2 years with a progressive disease without having any medical advice. So there is a lot of variation in the symptoms that the patient with pulmonary hypertension can present with. If we look to the examination, the patient may have a left parasternal uplift, the accentuated pulmonary component of second heart sound as our patient, the third heart sound and tricuspid regurgitation murmur or pulmonary regurgitation murmur. And neck veins would be elevated with ascites and lower limb edema. It's a classic symptom of right ventricular failure, but of course, this occurs in the late stage of pulmonary hypertension. So the most important step here is the echocardiography. The echocardiography is a gold standard for detecting the probability, and I said the probability of pulmonary hypertension. And it can also comment on the left heart, if we have a left heart disease or not. Let's discuss the imaging from this patient. She has a dilatation of the right ventricle. The dimension was dilated. The peak tricuspid regurgitation velocity and pulmonary regurgitation velocity were high. And tricuspid annular plane systolic excursion, TAPSE, and tricuspid systolic annular velocities are low, denoting that this patient starts to have a right ventricular dysfunction. The IVC is not it's not markedly dilated. However, there was a lack of inspiratory collapse, and our right atrium was dilated with a right atrial area of 20 centimeters square. So, based on this echocardiographic data, these patients have a probability of pulmonary hypertension is to be low or intermediate or high. So Haitham, what do you think?
I think it's an intermediate to high risk, and if it's a single answer, it's C.
Okay. And what about the audience?
All of them, all the messages now stating that either it's
start
high
voting
or
on the
intermediate to
Zoom
high.
chat. So for the audience can
Okay.
start voting on the Zoom chat. You can write the letter of the option. It's A low, B intermediate, or C high.
I'm seeing here, Muhammad, that most of the answers is C, high. And the most preservative answer is intermediate to high. So I think we are
have
all
a
agreeing
criteria
that
for defining the probability of pulmonary hypertension with echo. It can be low if it depends on two major parameters: the peak tricuspid regurgitation velocity and the presence of other echo finding of pulmonary hypertension. The peak tricuspid regurgitation velocity might be very low, less than 2.8 meters per second, and this goes with a low probability of pulmonary hypertension. It might be high, more than 3.4, as in our patients, and this goes with a high probability of pulmonary hypertension, or can maybe between these values. We have also the echocardiographic finding, the indirect evidence of pulmonary hypertension. We should look for the ventricles, the pulmonary artery, and the inferior vena cava and right atrium. The right ventricle may be dilated, and we have a flattening of the septum due to the pressure overload of the right ventricle. We might have a short acceleration time on the pulmonary systolic flow with a mid-systolic notching at the M mode, and increase in the pulmonary regurgitation velocity and pulmonary artery dilatation. Also, we might have a dilatation of the inferior vena cava with a lack of inspiratory collapse. This is all a criteria for diagnosing of pulmonary hypertension by echo. We are talking about the probability of pulmonary hypertension, not the confirmatory diagnosis of pulmonary hypertension. Please remember that. So we continue the study with the right ventricular function with the comment on the left heart to have a full echocardiographic study on the pulmonary hypertension patient. So based on the transthoracic echocardiography, the probability here is high. The next question is, what is the most common etiology of pulmonary hypertension? Is it A, idiopathic pulmonary arterial hypertension, B, secondary to autoimmune disease, C, secondary to the left heart disease, D, secondary to chest disease, or E, chronic thromboembolic pulmonary hypertension? So what do you think?
Karim, are you blackening the screen? The screen is offline.
Screen is offline?
Yes. So check your screen again, because we're seeing a black screen. We cannot see the presentation.
The screen is working. The screen is working, guys. And maybe this is something from your side, maybe, but it's working for everyone.
Now it's working.
Maybe it's a lag in the internet. No problem. Can you start with the question again, Karim, please?
Yes, please.
Everything is fine now?
Yes, it's perfect.
Yeah, everything is fine now.
Okay. So what do you think? Is it A, B, C, D, or E? Okay.
Okay, go ahead and participate, everyone.
Okay, you can write your answer.
We have 1A, the idiopathic pulmonary arterial hypertension. We're waiting for the others to participate. Another A. Dr. Hatim here say that it's C, pulmonary hypertension, secondary to left heart disease. Dr. Sharif C. So now we have a split opinion between the idiopathic pulmonary arterial hypertension and pulmonary hypertension secondary to left-sided heart disease.
Let's clarify this point. If we
Okay.
look again to the algorithm of pulmonary hypertension diagnosis, the next step is to consider left heart disease. And this is because that this is the causes of pulmonary hypertension due to the left heart disease. It might be systolic dysfunction, diastolic dysfunction, or valvular heart disease. And you should remember that we are dealing as a cardiologist with the most causes of pulmonary hypertension. The pulmonary hypertension secondary to the left heart disease constitute about 75% of cases. And you can suspect that if your patient is elderly, male, hypertensive, especially if he has risk factors as smoking, metabolic syndrome, or coronary artery disease. So it's a good point to remember the left heart disease is the most common cause of pulmonary hypertension, and it's the first cause that you need to exclude in the algorithm of pulmonary hypertension. And you can have this investigation like this in the cases of pulmonary hypertension secondary to the left heart disease, such as the left ventricular hypertrophy in the ECG or the atrial fibrillation, and the echo showing the dilated cardiomyopathy or mitral valve disease or aortic valve disease. So our patient has a normal left heart chamber and normal diastolic function, so we exclude the left heart disease in our patient. However, you should remember, as I mentioned before, that pulmonary hypertension secondary to the left heart disease is the most common etiology of pulmonary hypertension. If we go further in the algorithm, we should consider lung disease, and we should exclude the lung disease. And there is many causes for the lung disease, such as the obstructive lung disease, restrictive lung disease as interstitial lung disease, or sleep or obstructive sleep disorders. And you should remember that obstructive sleep apnea, the patient, if have obstructive sleep apnea, 70% of them might have a pulmonary hypertension, and you can do an investigation such as a sleep study. Pulmonary function test is important to differentiate between obstructive and restrictive lung disease in association with the diffusion lung capacity. And of course, the high resolution CT to detect the ground glass appearance in the cases of interstitial lung disease, and to detect COVID as well if this patient presented at these days.
Hopefully, it will not. He will not present to a cardiologist.
Hopefully. So we exclude the lung disease in our patient. She has a normal blood gases, normal pulmonary function. Pulmonary function test showed a mild obstruction that cannot explain the degree of pulmonary artery pressure elevation. So what is the next step? Please respond. Is it the right heart cath? Is it the CT pulmonary angiography? Is it perfusion lung scan? Or we should start the pulmonary arterial hypertension specific therapy immediately? Please respond.
We have here three answers till now that do prefer to do a right heart cath. 4, 5.
Okay. So most of the answers go with the right heart cath.
Yeah.
I'm afraid back to the algorithm, this is not the best next step. The next step is to exclude the chronic thromboembolic pulmonary hypertension. Of course, we can do the right heart cath at any stage, but according to the algorithm, the best next step is to do a VQ scan to exclude a chronic thromboembolic pulmonary hypertension. The exclusion of chronic thromboembolic pulmonary hypertension, or CTEPH, is crucial, as this patient, when treated appropriately with the pulmonary thromboendarterectomy, can have a normal, can return to the normal pulmonary circulation and can have a normal pulmonary artery pressure. So it's very important to diagnose the CTEPH, and if this patient is eligible to surgery, that surgery could be done for this patient. So the perfusion lung scan is the best next step. And if you have this perfusion lung scan, the above is a ventilation scan and the blue is the perfusion scan. How would you comment about this VQ scan? Is it normal? There is a right mismatch or left lung mismatch?
I think you will have to answer this yourself, my friend.
Okay. So to answer this, here is an example for the VQ scan. On the left side, you have more or less match between the ventilation and perfusion scan. On the other hand, on the right side, you can appreciate that we have a multiple perfusion defects, that they have a mismatch with the ventilation scan. So on the left side, we have a low probability of CTEF, and on the right side, we have a high probability of the CTEF. There is an important point that the VQ scan is more sensitive than, and sometimes than the CT pulmonary angiography. As sometimes the CT pulmonary angiography can't detect the subsegmental pulmonary occlusion. So the VQ scan can do that, while in some cases CT pulmonary angiography can't do that. However, if we have a high probability, intermediate to high probability of the CTEF, we should have a CT pulmonary angiography. Here you can appreciate a patient with CTEF. We might have this band or web. We might have an occlusion, a complete occlusion. We might have attenuation of the pulmonary circulation or dilated bronchial arteries. And we can comment also on the right ventricular dimension and right ventricular function. Of course, if this patient would be sent to surgery, to pulmonary thromboendarterectomy, we should have a conventional pulmonary angiography for complete delineation of the pulmonary circulation anatomy before going to surgery. Remember, the CTEF can be cured if the surgery is appropriately done. So this is a normal, back to the question, this is a normal VQ scan. And back to the algorithm, this is a rule for right heart case. We exclude that our patient have chronic CTEF, so the next step is to do right heart case. So speaking about the right heart case, if the right heart case showed a mean pulmonary artery pressure more than 25 millimeter mercury and pulmonary artery wedge pressure less than 15 millimeter mercury, this can be found in all following types except the scleroderma, pulmonary PAH with the scleroderma. Number B is the Eisenmenger syndrome, secondary to the persistent left to right shunt and reversal of the shunt. Bilharzial core pulmonale, the heart failure with a preserved ejection fraction complicated with pulmonary hypertension, or in the CTEF. Please respond. I think this is the area of your expertise, Haytham.
Yeah, but I prefer that we see more interaction. To know the clue, I think we need to think about what is increasing the left-sided pressure in all these disease, because the increase in left-sided pressure and left arterial pressure will raise the pulmonary artery wedge pressure. So we have a high pulmonary arterial pressure with low pulmonary artery wedge pressure. So I think that D is the exception.
Okay, so based that we have a high mean pulmonary artery wedge pressure, mean pulmonary artery pressure with a low pulmonary artery wedge pressure. Let's see first when we comment the right heart case. The right heart case should be done in the group 1, group 4, in the congenital cases, and if we have a suspicion about the type 2 or type 3. However, group 1 and group 4 and the congenital heart disease, these are the recommended cases for right heart cath. So the right heart cath is not indicated for every patient with pulmonary hypertension. And we have a recent modification for the definition of pulmonary hypertension. Actually, the latest World Symposium of the Pulmonary Hypertension stated that pulmonary hypertension can be defined as elevation of mean pulmonary artery pressure more than 20 millimeter mercury. And most of causes of pulmonary hypertension have a pulmonary artery wedge pressure less than 15 millimeter mercury, except for the cases with a left heart disease, as in the heart failure with a preserved ejection fraction, which have a pulmonary artery wedge pressure more than 15 millimeter mercury. And the pulmonary vascular resistance is very important parameter that we should report in the right heart cath as well. So back to our patient. Our patient have an elevated pulmonary artery wedge pressure, elevated mean pulmonary artery pressure, and a pulmonary artery wedge pressure less than 15 millimeter mercury. It can be found in all types of pulmonary hypertension, except in the pulmonary hypertension secondary to left heart disease. If you decided to do a vasoactivity test during the right heart cath, which type of this pulmonary hypertension patient you would recommend the vasoactivity test? The vasoactivity test meaning that you would give the patient certain drug and see the response of the mean pulmonary artery pressure. Is it the heritable pulmonary arterial hypertension, heritable or familial pulmonary arterial hypertension? Is it the autoimmune type secondary to scleroderma or systemic lupus? Is it the HIV? Is it the secondary to the mitral stenosis or the portal pulmonary hypertension?
Allow me to give a hint for this question. It might help to answer. So vasoreactivity test is testing with if the pulmonary artery will respond and dilate or not. So if there is a reserve in the media of the pulmonary artery, and if this pulmonary artery did not turn out to be a block of fibrous tissue and has a reserve of elastic tissue. So can we guess? So we have two answers for A.
Okay. Any more? Okay.
Come on, guys.
Let's see the answer. The vasoactivity test, meaning, as I mentioned, giving a drug for a patient with pulmonary hypertension during the right heart cath and see the response of the pulmonary artery pressure. If it is in an early stage, it can be vasoreactive. And if it is in the late stage, it will be a non-vasoreactive. And actually, most cases on the types of pulmonary arterial hypertension should be considered as a non-vasoreactive, except in the cases with idiopathic pulmonary arterial hypertension, irritable pulmonary arterial hypertension, and the pulmonary arterial hypertension secondary to drugs, such as anoxygenic drugs. These patients can be a vasoreactive and can respond to the calcium channel blocker. So this is the three causes that we should do a vasoactivity test for them. And the drug that we will use is nitric oxide or ibuprostenol or adenosine. And we would define the positive response as a drop of mean pulmonary artery pressure more than or equal 10 millimeter mercury to a value less than 40 millimeter mercury with increased or unchanged cardiac output. We must satisfy the three criteria for the positive response. Why the vascular activity is very important? Because it helps to detect which patient will benefit from the calcium channel blocker. And actually, these patients are less than 10% of the patient with pulmonary arterial hypertension. So not every patient with pulmonary arterial hypertension is recommended to have calcium channel blocker as a therapy. So the heritable or familial pulmonary arterial hypertension is the state and the condition that the vascular activity is recommended. So back to our patient, his right heart cath showed the mean pulmonary artery pressure of 50, right atrial pressure of 10, and the pulmonary artery pressure of 6. Remember this value, you know that it is not due to the left heart disease. So we comment about the pressure. We comment also about the resistance. The pulmonary vascular resistance was elevated, reaching 15 Wood unit. The cardiac index was a borderline, and mixed venous oxygen consumption is low, reaching 63%, and our patient was non-vasoreactive. A more complementary modification for right heart cath that to do a pulmonary angiography in the cases with the CTEP. But in most of the rest of cases, we comment about the pressure, resistance, cardiac index, saturation, and vascular activity if the patient within the 3 groups that we mentioned before. So we diagnose this patient as a definite pulmonary arterial hypertension.
وعطيه معلش ريحي بقى شويه.
So to know if this patient have a cause for the type 1 or group 1 pulmonary arterial hypertension. So we should search by history and by investigation for the causes of pulmonary arterial hypertension. We should search for drug history, the familial history, and history of liver or thyroid disease, the connective tissue disease such as joint pain, myalgia, rash, or Raynaud's, or history of bilharziosis, and doing some investigation such as anti-nuclear antibody and scleroderma antibody, thyroid function, screening for HIV, echo for congenital heart disease, and abdominal ultrasound for liver disease. And of course, we won't do all this investigation, and we select the investigation according to the clinical scenario. So our patient turned to be idiopathic pulmonary arterial hypertension. So you diagnose these patients and you need to do a risk stratification. Which patient is low risk, intermediate risk, and high risk. So all of the following are considered the high risk criteria, except that the mean pulmonary artery pressure is 50 millimeter mercury, the presence of a precardial effusion, the 6-minute walk distance is 150 meter, or a right atrial pressure of 10 millimeter mercury. Please respond.
Okay, we have now 3 votes for A. The mean arterial pressure is 50 millimeter mercury. 4 votes for A.
So
I think they are voting for the A, Karim.
okay.
The mean arterial pressure is 50 millimeter mercury.
So you are saying that the pulmonary artery pressure is not an indication for the high risk criteria of in the patient with a BH? You are correct. Actually, the all risk criteria for the risk assessment didn't include the mean pulmonary artery pressure as a risk criteria. If you look, we have a clinical criteria such as heart failure, the progression of symptoms, the syncope, and the functional class. Here, the state of our patient. Have the exercise parameters such as the 6-minute walk distance and the cardiopulmonary exercise test. We have investigation parameters such as the NT, Pro-BNP, and the imaging for echo comment about the right atrial area and the pericardial effusion as the risk criteria for pulmonary arterial hypertension. And of course, we have the hemodynamic, which consists of the right atrial pressure, the cardiac index, and the mixed venous oxygen consumption. So most of criteria for our patient lay in the intermediate risk group. And as you mentioned, this is correct. The mean pulmonary artery pressure is not a risk criteria, is a risk criterion for the pulmonary artery hypertension risk assessment. And we now have a more updated risk score, such as this score is called a Reveal 2 score. We have this parameter. Some of them are clinical parameter and some of them investigation and right side case. And if we have a value more than 9, this indicates that this patient has a high risk pulmonary arterial hypertension. So going to the management of this patient. This is the last part in the presentation. You might allow the patient with pulmonary arterial hypertension to get pregnant if she showed a good response to medical treatment. This statement is true provided that the 6-minute walk distance more than 440 meters. It's true provided that the mean pulmonary artery pressure decreased more than 10 millimeter mercury. This is a false statement, or A and B are true.
I think the majority here is against pregnancy.
Thank you
of the
so
patient.
much. This is the general measures for the pulmonary arterial hypertension. The patient shouldn't have exercise should have a supervised exercise, and shouldn't have a heavy exercise. The female patient shouldn't be pregnant, and the patient should have the influenza vaccine every year. And I think after COVID vaccine will be discovered, they should have also the COVID vaccine. And they should have a psychosocial support and the oxygen during the flight. And we have some supportive therapy, such as diuretic therapy if the patient have a right ventricular failure, the continuous long-term oxygen if they are hypoxic. The oral anticoagulant have a little evidence to be given in the patient with pulmonary arterial hypertension, and we shouldn't use the drugs for the heart failure except if we have a comorbidity or an indication for them. So the last part in the puzzle is specific therapy for the patient with a pulmonary arterial hypertension. And of course, the answer for this question is false, as you all mentioned. This is the last question here. This patient is considered to have intermediate risk, and the best initial therapy is a monotherapy with either phosphodiesterase 5 inhibitor or endothelin receptor antagonist, or combination therapy with calcium channel blocker and phosphodiesterase 5 inhibitor, or a combination therapy with endothelin receptor antagonist and phosphodiesterase 5 inhibitor, or a combination therapy with a prostacyclin analog and endothelin receptor antagonist. I know this is a tough one, but I'm sure that most of you will get it.
We're getting 3 votes now for C, the combination of phosphodiesterase inhibitor and ERA.
Okay.
More votes, 7.
7 for C.
Yeah, endothelin receptor antagonist with phosphodiesterase 5 inhibitor.
Okay. So let's see more algorithm and one more final algorithm for the pulmonary arterial hypertension. After you excluded that this patient, if this patient is a vasoreactive, you can give him a calcium channel blocker in a large dose. You can give a calcium channel blocker not in the usual hypertensive antihypertensive dose. You give the calcium channel blocker in a high dose. And if your patient is non-vasoreactive or having any other form of pulmonary arterial hypertension, you should go with the risk. If this patient have a low intermediate risk, most of these patients right now should have an initial oral combination therapy. And the monotherapy should be reserved for a selected cases, and I will mention them later. But if the patient have a high risk criteria, he should have an initial combination therapy with IV prostacyclin analog. So our patient has an intermediate risk, so she should have an initial oral combination. So the phosphodiesterase 5 inhibitor and the endothelin receptor antagonist would be good for this type of patient. And after 3 to 6 months, you should assess your patient. If she goes into the low risk criteria, you will follow her up. And if she had a more symptom and she didn't improve, you will go with a triple sequential therapy. So the data from the combination therapy came from several trials, and this is the most important one called the Ambition trial that compared the ambrisentan with tadalafil in comparison with the monotherapy, and they showed a favorable response regarding the hemodynamics. So the monotherapy should be reserved for the patient with a vasoreactive pulmonary arterial hypertension. If you are afraid of the hemodynamic in an elderly patient with a multiple risk factor, in a subtype which is a pulmonary venous occlusive disease, we might talk about this type of disease later on, and HIV or portopulmonary hypertension, or if this patient have a mild disease with a mean pulmonary artery pressure less than 30 millimeter mercury. So the correct answer is actually C. So back to the first slide in our presentation. You should know the probability of the pulmonary hypertension, and the echo would help. You should search for the cardiac and lung causes. You should exclude the CTEPH, it's curable. You should, when you reach a diagnosis of BAH, you should search for the cause and do a right heart cath. Following that, you should risk stratify your patient, and accordingly, you should give a treatment which in most of cases should be a combination therapy rather than a monotherapy. And thank you.
Thank you, Dr. Karim, for this valuable information and the presentation. And I think you've mentioned the importance of teaching the patient and joining the patient in a rehab program to adjust the lifestyle and to adjust the way he is treated and the way he will treat others, and the scheduling also of his medication and the investigation follow-up them.
Thank you so much, Karim. Actually, you took a very tough topic and you started it smoothly and easily, and we didn't feel that it was so tough when you were speaking, because you took us step by step. Actually, I think you highlighted very well here the importance of risk stratification of the patient, and that it's not just a simple measurement of how much millimeter mercury is on echo. It's a little bit more complex, and calcium channel blocker is not useful for all the cases of pulmonary hypertension, so it should be prescribed with caution. And you focused on the secondary causes, and finally the idiopathic primary pulmonary arterial hypertension. So we
have a question.
Yes,
Zaharon?
Yes, I was gonna offer everyone. You can put your questions here on the group chat, and we will be asking them to Dr. Karim so he can reply publicly to everyone. So every one of us will learn and improve his practice. So Haitham, you can proceed.
Okay, so the first question is why we shouldn't use calcium channel blocker rather than invasive right heart cath if the patient can tolerate it.
Okay. Because the response for the calcium channel blocker, the patient that would respond to the calcium channel blocker represent a minority. They are less than 10% of the patient with a calcium channel blocker. So if we don't have an evidence that this patient would benefit from the calcium channel blocker, he shouldn't receive the calcium channel blocker. And if, as I mentioned, the three groups that would benefit from the calcium channel blocker are the idiopathic, the heritable, and secondary to the drugs. These are the three groups that you should test the vasoreactivity in them. If these patients are vasoreactive, you should give them a calcium channel blocker in a high dose. If they are non-vasoreactive, and this is the majority of cases, you should continue with the rest of the management as I mentioned.
Okay, we have a couple of questions from Dr. Ahmed Mansour. The first one is how to estimate pulmonary vascular resistance in right heart cath.
Okay, I see the questions and I would answer. The pulmonary vascular resistance in the right heart cath depend on the multiple measures that you need to measure first and to calculate first before going to estimate the pulmonary vascular resistance. These are the mean pulmonary artery pressure, the pulmonary artery wedge pressure, and the cardiac output. The mean pulmonary artery pressure and the pulmonary artery wedge pressure, you can gain them by introducing your catheter into the pulmonary artery and then into the wedge. However, the cardiac output, you need several parameters such as the body surface area, the hemoglobin. These parameters, as you measure these parameters and the saturation, the pulmonary and the mixed venous oxygen saturation, and the arterial saturation. When you get all these parameters, then you go to your calculator and enter this parameter into the calculator. You can get the cardiac output by assumed Fick method, which is commonly used in our practice. And then you can get the pulmonary vascular resistance by getting the mean pulmonary artery pressure, pulmonary artery wedge pressure, and the cardiac output. For the second one, when to refer a patient to a cardiac surgeon with CTIF, I think you should refer every patient with a CTIF to the cardiac surgeon. If you are sure about the diagnosis, you should refer every patient. And you should have a discussion with a cardiac surgeon, with an experienced cardiac surgeon, about the possibility of surgery in this patient. You can give a hope for this patient if he is appropriately managed. So in some cases, it can be managed with acceptable risk. However, in some cases, this patient can not be managed and need some other parameters such as drugs or recently the balloon angioplasty for the pulmonary circulation in the case of the CTIF. The third one is there a rule for interventional cardiology in idiopathic pulmonary hypertension? The only rule right now for pulmonary arterial hypertension for the idiopathic one is to diagnose it by the right heart cath and getting the multiple parameters as we mentioned, such as the pressures, resistance, cardiac output, and the cardiac index, the saturations, and the vasoreactivity. Okay. Haitham.
So
دكتور هيثم ممكن اسال سؤال؟
ده حضرتك تنورنا.
ربنا يخليك يا حبيبي. انا بس الجزئيه بتاعت الجايد لاينز ان انت دلوقتي الرايت هارت كاس از فيري امبورتنت تو اول حاجه اشور الدايجنوزس اوف pulmonary hypertension. So why to go for cost for VQ mismatch؟ يعني ليه انا اعمل الاول برفيوجن سكان قبل ما اعمل رايت هارت كاس، مع ملاحظه ان احنا هنرجع نعمل رايت هارت كاس لو انا برضو حتى لقيت ان هو سيتير هعمل رايت هارت كاس الاول وبعدها هعمل بالمونري انجيوجرافي. طب ليه ما اعملش الاول رايت هارت كاس؟ ممكن الاقي ما فيش بالمونري هايبرتنشن والاستيميشن بتاع الايكو غلط، واوفر على المريض ان هو يعمل البرفيوجن سكان. دي النقطه بس اللي عندي اللي انا مش مقتنع بيها في الجايد لاينز. اسمع راي حضرتك.
طيب خلينا حضرتك دكتور حاتم, thank you for your question and يعني nice opportunity to have you among us. هو طبعا of course the VQ scan is a non-invasive imaging and right heart cath is an invasive imaging, and actually the right heart cath and subsequent pulmonary angiography needs skills and needs expertise, and actually it's an invasive procedure. The VQ scan is very important for diagnosing certain population of patients which are the CTEF, because it has a high sensitivity for detecting such type of patient. And if we revise the latest World Symposium on Pulmonary Hypertension, they even make the VQ scan before the searching for the heart and lung causes, because it's very important to detect if this patient actually have a chronic thromboembolic pulmonary hypertension. So the answer for this, for your questions, that I actually do many cases with right heart cath and pulmonary angiography. The pulmonary angiography is not so easy. We need many information. This information we need most information we need can be handled by the VQ scan, the CT pulmonary angiography, before we going into a confirmation or last confirmation with the pulmonary angiography. So the VQ scan is non-invasive test. It can be simply done in the experienced center, and it gives us a lot of information that we need to exclude the patient with the CTEF.
So we can give message for all cardiologists. If you got a patient with pulmonary hypertension in echo, not explained by left-sided heart or congenital heart, you should go for perfusion scanning first to rule out CTEP before thinking to give any medication for pulmonary hypertension.
Definitely.
That's right.
Definitely, and thank you for this.
Thank you. Thank you.
There is a question about the availability of pulmonary arterial hypertension specific drugs in Egypt rather than sildenafil, tadalafil, and bosentan. I think that ambrisentan is available in Egypt.
Okay. You know, Haitham, the issue, most of the oral drugs are now available. Actually, the Selexibag it's available or about to be available, which is an oral prostacyclin.
Yeah, it's coming soon. Yeah.
Yes. However, the IV form and subcutaneous, which is the ibuprostenol and the terbostenil, we don't have actually, except in the, some centers that, such as Aswan Heart Center. It's very expensive. These types of drugs are very expensive, and they are not available for every PH patient till now. But the oral drugs are available, and a lot of patients can improve on these oral drugs.
Okay, there is a tricky question after surgical or balloon intervention to the CTEF patient. If this female is allowed to get pregnant or not?
If she has CTEF.
And this CTEF is treated by balloon dilation or surgical intervention.
Okay. Actually, I don't have data for answering this type of question. However, I think by extrapolating to other diseases that we are dealing with, if our patient has a good response after treatment and can lead a healthy lifestyle with no residual pulmonary hypertension, I think can allow this patient to get pregnant.
Yeah. Taking into consideration that you mentioned several times that the CTEF type of pulmonary hypertension is curable by these types of intervention.
Yes, if it's done appropriately, yes.
I'm sorry to interrupt. I think regarding pregnancy, we should also check thrombophilia. Yani as we get a patient with CTEP, we should check if she has hypercoagulable state, and to take decision that if she get pregnant, she will be anticoagulated throughout pregnancy or not.
Good point. And actually, these patients should continue on anticoagulation for life.
Yeah.
Without stoppage, even after the correction of pulmonary correction of CT.
This is the object of my comment, that this patient, yes, if she go back normal pulmonary artery pressure, she can go back for pregnancy, but she should be anticoagulated lifelong.
Yes.
Okay, so there is another question: the role of pulmonary arterial denervation in idiopathic pulmonary hypertension. And a comment that it's a huge mistake to use calcium channel blocker instead of adenosine during right heart cath. I think that there is no role for calcium channel blocker in our practice doing right heart cath.
Yes.
So Karim, back to the question. Is there a role of pulmonary arterial denervation in idiopathic pulmonary hypertension?
I think there are some research data about this type of intervention. However, I don't recommend it till now. I think we need more data if this type of intervention could work in this type of patient.
Okay. Any other question?
So actually, this is our first webinar. It was supposed to be incorporated with a live transmission on the YouTube channel, but something crashed down immediately before the meeting. So we were lucky enough to have this professional account on Zoom, so we can include numerous participants. So actually, you were all with us inside the meeting room because we expected that maybe our number would exceed the capacity of the meeting room. So actually, before the meeting started, we bought a very big room on the Zoom.
I'm sorry.
Yes.
I'm sorry, Muhammad. There is a couple of questions.
Okay.
One of them we've skipped accidentally.
Let's finish the questions first.
Yeah, the algorithm of type 4 pulmonary hypertension, that of treating type 4 pulmonary hypertension. Dr. Sharif Nagy asked for this question.
Okay, this algorithm is continuously updated because and it is updated in the last pulmonary embolism guidelines because of the importance of for management of this type of patient. So if you have a patient with pulmonary embolism, you should have an adequate anticoagulation for at least 3 months. And you should later on, if these patients still have symptoms or an increased pulmonary systolic pressure on echo, you should investigate for the chronic thromboembolic pulmonary hypertension by doing a VQ scan or CT pulmonary angiography. And if you confirm the presence of CTEPH, you should go to the conventional pulmonary angiography and see if this patient is candidate for surgery or not. If he is surgically fit, he should go to pulmonary thromboendarterectomy. And if he is not, you have an option such as the balloon pulmonary angioplasty for the peripheral. Actually, this is for the peripheral pulmonary thrombi, or you can give only drugs such as riociguat for dealing and for managing the hemodynamics in the patient with a chronic thromboembolic pulmonary.
Okay, there is a tricky question that if you have an indirect evidence of CTEPH or high probability of CTEPH by having a significantly dilated right ventricle and pulmonary hypertension by echo with no VQ scan available, do you subject these patients to oral anticoagulation?
Can you repeat the question, please, Haytham?
If you have a patient with dilated right ventricle and pulmonary hypertension evident by echo with no VQ scan, is it practically to subject these patients to oral anticoagulation or not? We have dilated right ventricle and we have pulmonary hypertension by echo.
So you are speaking about these patients have a high probability of pulmonary hypertension, and you are in the process of searching for the cause, and you are suspecting that these patients have a high probability of chronic thromboembolic pulmonary hypertension, but
Yes.
the VQ scan is not available in your center. You can go to the second line, which is a little lower sensitivity than the VQ scan, which is the CT pulmonary angiography. I think the CT pulmonary angiography is available in most of the centers now for evaluating of the pulmonary circulation. But I think you should have a diagnosis for you should have a diagnosis for a chronic thromboembolic pulmonary hypertension before prescribing this patient lifelong oral.
Two brave and intervention questions. The first one is the availability of pulmonary artery denervation in Egypt.
No, it's not available, and it is a research
Okay.
tool.
Yeah, and the second one is to do
actually we might have these severe pulmonary hypertension, and they are not responding to the usual measures such as diuretics, troops, and pulmonary arterial hypertension specific therapy. This can be done as a bailout. It can be done as a bailout solution or as a bridge for a heart-lung transplantation when it is available. Yeah. So I prefer to reserve that for very severe cases. Should be this management should be individualized and should not be the management for every patient.
Okay.
So I think we don't have.
So this
any
is
more
either
questions.
you failed.
Okay. Proceed, Haitham, please.
No, there is no more questions.
Okay, so maybe so does someone like to ask a question on the chat? Okay, so we are actually
I think we have
regarding the team,
a last center, which is a very important one. Yes, it's recommended to refer the patient with a pulmonary hypertension. If you suspect a patient with pulmonary hypertension, to refer him to a pulmonary hypertension referral center. This is a good question. And the obstetrician, any a lot of specialty should be referral